vaccines. As usual, we'll start with the very latest facts and figures, and then the whole panel will be taking questions from special guests, press and members of the public. And to start us off, here is Professor Christina Pargle with the week's facts and figures. Over to you, Christina.
Hello. Right. So today's figures. Well, there are positive signs everywhere, except perhaps Wales, which we'll look at in a little bit. And I think the message of Wales and actually of Scotland, as we'll see, is that coming out of restrictions, which we're now doing in England, is hard. So I'm going to start by looking at cases and kind of lockdowns and restrictions, and then very briefly just show you what's happening in hospitalizations and deaths, and then spend a little bit longer at the end just looking at the kind of the new tiers and why they might have been chosen in England, and the role of mass testing. Just one slide on that, even though I spelt it wrong. So cases. This is confirmed cases by reported date over the whole of the UK. And you can see now that it is starting to come down quite steeply, but obviously this is a mishmash of all the different nations. So if we look at it by nation and looking at it by day the test was taken, which is a better way of kind of assessing the impact of new interventions like lockdowns or restrictions, you can see that every country is, every nation is decreasing. Well, almost every country, but Scotland, Northern Ireland, and England are all now having cases decreasing. England later than everyone else because we had a lockdown later than everyone else. But Wales, the Welsh cases are going up. So they had a 2-week fire break the last week of October and the first week of November. Cases continued going down for about a week after that, and you'd expect that because that's kind of baked into the system, just as we would expect that coming out of our English lockdown. But then cases have started going up again. But we really need to look at positivity rate to know whether that's an impact of testing, because there has been more testing in Wales. And if you do look at positivity rate, this is positivity rate for UK nation. So the proportion of people who test positive, it's not quite as clear that it's going up, but the last few days have seen an increase in positivity rate in Wales. And the Office of National Statistics released their infection survey today. And they also said in Wales that the very last week, and it goes to the same date, 28th of November, as this graph has gone up a little bit. And Wales is now instituting, as of today, an alcohol ban. So they're obviously reacting to this information. And I think that just goes to show that you can have an effective fire break, which Wales did, and then coming out, it can still then start to go in the wrong direction reasonably quickly. And now I just wanted to have a look at the regional look at Scotland, which is this blue line, because I actually think now that they've gone into their 4 levels or 5 levels, but no one's at level 0, it's actually really interesting to see what's happening there. So I showed this plot 2 weeks ago. So we're now 2 weeks on. There are four kind of bands in Scotland that are in different levels, 1 to 4, with 4 being the most restrictive. Originally, beginning of October, there were just kind of restrictions in the central belt. Then on the 2nd of November, it became Scotland's 5-tier system, but only 3 levels were used. And then a couple of weeks ago, these dark areas were moved up into level 4. And what you can see since then is that their cases, their positivity rate has started to, it was going down already, but it's coming down faster now. Whereas the places in levels 1, 2, and 3 have actually stayed pretty flat. And I think what's interesting there is it kind of shows that if the levels are kind of appropriate to your current case numbers, you can be at different levels and still stay flat. And what's interesting, I think, for Scotland is that is whether they think they can manage keep in all these areas in the health system and keeping it flat with those restrictions, or whether there's any scope for either loosening restrictions or whether they want to get cases down further. And for England, what's interesting is that level 4 is quite similar to the English lockdown, and it seems to be having quite an impact in Scotland as it did in England. But levels 1, 2, and 3 are actually quite similar to our English tiers. And so now, as most of the country is going into levels 2 and 3, are we also going to basically flatten off now for the weeks to come? So I think it's kind of very interesting to look at Scotland. If we look at the English regions, we can see that every region is now decreasing in cases, and some quite a lot, like the Northwest now has the same level of cases per 100,000 as London, for instance. So it's definitely having quite a big difference now in the North compared to where they were in the middle of October. And just looking at the positivity rate, we have to be a bit careful about positivity rate in the Northwest because of the impact of the mass testing trial there. But again, it's coming down everywhere, which is good because we want it to come down. But you can just see the last couple of days in London, the southeast, and the east of England, it's kind of flattening off. And I think now that we're coming out of lockdown, it will be really important to kind of keep an eye on these regions to see what's happening there. And in fact, the southeast, a lot of the southeast is going into the highest tier because they are having issues there with cases growing. Then there's also some good news about age rates. So for the first time, really, we're now seeing cases reducing across all age groups, including school-aged children. This is from the ONS survey released today. The Imperial React study, which tested 100,000 people recently, sorry, that's my post, that tested 100,000 people recently also found the same thing, that cases are now decreasing across all age groups. And what that means is likely that now that community transmission is reducing, it is now kind of feeding into schools as well. And the other thing that the ONS released this week, they have a weekly social survey where they look at people's behaviours. And one of the questions they ask is, have you left home to meet a person outside your household? And they looked at the 2 weeks before lockdown and the 2 weeks after lockdown. The 2 weeks before lockdown are the blue dots, and the 2 weeks after lockdown are the red dots. And all I really want you to see is that every single place it's come down. People are going out a lot less to meet people from other households, which is what you would hope would happen. And the biggest changes have been in the tier 1 and the tier 2 areas. Again, not surprising because they had more freedoms before. But, you know, given that people are seeing people less, it's not surprising that the transmission rates have come down as well. So just thinking now that England is coming out, well, has come out of lockdown this week, this is just the daily reported case numbers in England since lockdown, since a week after lockdown. And all I've done is just added on a very, very simple chart of exponential decay at different rates. I haven't even fitted it, it's just kind of seeing, because what I want to see is over the next week, where we might be by next week, because basically we would expect cases to keep reducing for another week, that they will continue to fall probably. And so hopefully by next Friday, we should be seeing daily case numbers below 10,000, which is a massive improvement from the 25,000 we were at before. However, that's where we were beginning of October. It's still quite high and a lot higher than we were at the beginning of September and over the summer. What happens after that all depends on how well the new tiers work. And I'll talk about that a bit in a bit. So just quickly on hospitalizations, just looking at new hospital admissions across the nations, they're coming down everywhere. Wales records it differently, so it's quite different. It's much bumpier kind of data, so it's harder to look at. But even in Wales, you can see that it is starting to come down. So this is good news. And in the English regions, you can see that it also is good news, and particularly for the North Eastern Yorkshire, which have by far the highest level of admissions, it's now coming down very quickly. So this is just really good. Looking at deaths. So the weekly registered deaths from the Office of National Statistics, which are quite lagged, this goes up to the week ending 20th of November. So they're still going up. There were just over 3,000 in that week, but it's definitely slowing down. So that is good news. So you can see it's like it was doubling every 2 weeks, but it's nowhere near double the 2 weeks before. It goes up to the week ending 20th. And if we just look at the daily reported deaths in England, you can see that it does look like we have now reached a plateau, and hopefully the next week, when I show this plot, will have started coming down. So I think that that is really good news. But I mean, the bad news is that we let it get this high, but it has now, I think, turned a corner. So just a couple of slides on English tiers and other kind of mitigations now that we have come out of lockdown. So Sage released these minutes last Friday, one of which was this document, SO 920, where they considered the impact of the previous tiers, the ones that started in the middle of October. And they got a lot of extra data from PHE, Public Health England, to do this analysis. And what they did was effectively plot the regions in each tier on this graph. And this is growth rate in the 2 weeks before the tier started and growth rate the 2 weeks after the tier started. If you're on this right-hand side, it means the cases were growing before the tiers came in. If you're in the left-hand side, it means cases were shrinking before the tiers came in. And then if you're in this bottom right-hand bit, it means that it was growing before, but after the tiers came in, it started shrinking. So that means the tiers worked and cases started coming down. If you're in this section, it means it was growing before, the tiers have slowed you down, but it hasn't actually made it shrink. And if you're up here, it means they've actually not done anything and you're still growing more quickly afterwards. So that's kind of what they did. And what they did is plotted each region on this graph. And so this was tier 3. So you can see almost all the tier 3 regions in this bottom right-hand corner, which means they were growing before the tier 3s came in and started shrinking after. And so Sage said that tier 3 was associated. I mean, it's not, you can't prove it caused it, but it's associated with a shrinking pandemic in almost all areas. So it looked like tier 3 did work, but it took a few weeks for that to kind of show up. For tier 2, it worked in some places, or at least some places were growing before and started shrinking after tier 2 came in. Most places were in this kind of triangle, so it slowed down growth but didn't reverse it, and a few growth carried on accelerating. Tier 1, it was just kind of a big splodge, and so if looking at that, you'd say tier 1 didn't really seem to have any obvious impact on anything, the previous tier 1. So this kind of, I think, informed the new tiers, where effectively what they've done is they've made them a bit harsher, and we're kind of, so the new tier 2 is kind of the old tier 3 with a few extra freedoms, and the new tier 3 is the old tier 3 plus a few extra restrictions. And what this plot is just showing you is the current number of cases for areas in new tier 1, so the ones with the least restrictions, and there are only 2 regions that are in this, and just separated out by region. Now for tier 1, it doesn't really make that much difference, but it does when you look at tiers 2 and 3, because the different regions over the last 2 months have had really different trajectories, so it does kind of matter. So here you can just see there's, reasonably lowish case rates. This is now per day, not per week, so they're still a lot higher than they were in the summer. But also coming down after lockdown. The tier 2 regions, places in the tier 2 regions This is the northwest. Everywhere is coming down noticeably higher than the places that have been put into tier 1, and all kind of roughly within about 10 to 30 cases per 100,000 per day. This is not per week, but per day. And the places going into tier 3, again, noticeably higher than the other regions, also coming down quite rapidly, except the places in the southeast, and this is Kent. So Kent shows a very different kind of pattern to the other tier 3 areas, which are in the north of England and have been under restrictions for a long time. And even though they're coming down really rapidly, I think one of the reasons that these places have ended up in tier 3 is because of hospitalization. So this is the number of people in hospital right now by region, regardless of tier, it's just by region. And you can see that the Midlands and Northeast and the Northwest, where many of the new tier 3 regions are, have a really high hospital occupancy due to COVID. And if what happens in Scotland happens here, when we stabilise at that kind of level, and you're stabilising quite high level hospital admissions, then that will still risk really overwhelming or stressing your NHS. So I think the idea is we have to keep that down. We have to bring hospital occupancy down much further before you can risk releasing restrictions. Finally, just a couple of slides. Firstly, just on test and trace. We called for test and trace to be completely reformed during lockdown. It certainly hasn't been, but there are signs that things are getting a little bit better. So basically it's reaching people quicker, test results are coming in quicker, but it's not really reaching more people. So it's good that it's improving, but it's certainly not improving quickly enough. And just one thing on mass testing. This is a plot showing the number of lateral flow tests, which are the kind of new rapid tests that they've been trying out, used across the different regions over the last 4 weeks. And you can see up until a couple of days ago, it was almost all blue, so almost all in the Northwest. So that's mainly the Liverpool trial. And in the last couple of days, it's now moved across the rest of the country. So 25 to 30,000 lateral flow tests a day over the last couple of days. That is about 10% of all the tests carried out a day in communities. And if this keeps going up, because what they're doing is they're reporting the cases and the results of these all together, it's going to be really difficult to understand the case numbers quite soon, because it's quite a different people. If people have symptoms and get tested, that's telling you something different than if you just test the random population and see who's got COVID. And it'll make it really hard to know whether are we seeing more cases because we're doing mass testing, are we seeing more cases because there's genuinely more COVID, and the positivity rates will be really hard to interpret. And so it's just going to make it difficult going forward to use case data if they don't start disaggregating results by the type of test. So just to kind of finish, case numbers and hospitalizations are coming down, and deaths should soon start coming down. And Wales is something to keep an eye on. They are putting in new restrictions today. We'll kind of see what direction that goes in over the next week or two. In Scotland, levels below lockdown, so levels 1, 2, and 3, seem to be keeping things flat rather than decreasing. And in England, we should expect to see cases keep reducing over the next week, so continuing to fall. And then after next week, we'll kind of see what impact the new tiers have. We might be below 10,000 cases a day again by the end of next week. But the question is, will they keep going down, or will they kind of stabilize? Because stabilizing at 10,000 a day is quite high, especially as we move into Christmas. I haven't said anything about Northern Ireland because they're still in quite strict lockdown and their cases are still carrying on reducing. The aggregation of results from mass tests and tests from only those with symptoms, because they lump them together, it's just going to make interpreting the data really difficult. So I'm really, really hoping that they update the dashboard. Next week, I want to have a look again at the international picture, because other countries in Europe have come out of their versions of lockdown over the last couple of weeks, and we should be able to start seeing, what can we learn from them? How's it going? Are they keeping cases down? Are they going up again? And also we should be able to start looking at the impact of Thanksgiving in the US. which was last week, to see whether that caused a spike, because effectively, if it did, it will again give us something to think about over Christmas. And then also next week, we're going to be spending the session discussing the new vaccines and hopefully addressing some really common concerns about them. We'll be joined by an expert vaccinologist as well. And that's it from me.
Thank you very much, Christina. Fantastic summary of the facts and figures for this week then. Grounds for optimism, reasons to stay vigilant, and very interesting to see the analysis which underpins the tier system as well. And you keyed up vaccines. So now Professor Deenan Pillay is going to take up that theme. Deenan.
Hi, everyone. Thanks, Alice, and great presentation, Christina. So just briefly, last week we introduced our vaccine recommendations following the press releases on 3 vaccines previously. And these recommendations focused on, first of all, accountability, including transparency in reporting results. Secondly, communication, how best to reassure the public about the benefit. And thirdly, implementation, both operationally, how these vaccines are rolled out, but also to ensure that vaccines are rolled out in the context of a continuing anti-COVID strategy, including social distancing, test and trace, and so forth. So, and I think it's fair, and the last week has seen that a key concern remains, in fact, strengthens as a concern, remains a significant number of individuals who remain hesitant about vaccines, and how best to ensure that their concerns are dealt with so we can ensure that vaccines have maximal effect. So come Tuesday, or I think it was Tuesday or Wednesday rather, this week, and the announcement by the Medicines and Healthcare Products Regulatory Authority, the MHRA, that they had approved the Pfizer-BioNTech RNA vaccine. A vaccine developed by Turkish origin scientists in Germany, based on work funded over many years by EU grants, produced in collaboration with Pfizer, a US-based pharmaceutical company. And that press conference, I don't know about you, but it was amazingly refreshing to hear a press conference, which was a pleasure to watch. Messages on approval were matter of fact, authoritative, and undertaken by professional regulators and the chairs of the scientific and medical committees which guide that MHRA process, quite in contrast to the hyperbole and political nature of many of the government press conferences on COVID to date. But within a few hours, government ministers were making wildly inappropriate comments about the brilliance of the UK, how we were ahead of the rest of the world, and even that we could only do this because of Brexit. And unsurprisingly, there was an immediate response from the European Medicines Agency, European Ministers of Health, and even Tony Fauci in the US, saying that this was not a race and that time was needed to ensure safety of future vaccine recipients. It seemed actually that once again, the UK was snatching chaos from the jaws of sanity, and in the process, merely potentially adding to vaccine hesitancy. Now, we trust the MHRA process, the rigorous process by which they're going through approval of these vaccines. And we trust the EMA as well. However, it's clear that we need to ensure that hesitancy is dealt with, that we are able to convince those who are hesitant in the population, particularly those subgroups probably at highest risk of acquisition of infection, who we need to convince them of the merits of vaccines. And we would urge the MHRA and government to negotiate with trial investigators and sponsors of trials to make data available for public scrutiny, even before the usual scientific publication process, which is the standard way in which these data become available. In other words, some of the data that has been shared in confidence with the regulators, we do think should become more available. And indeed, as more vaccines become approved, then we can imagine a useful dashboard being developed using those data, which can continually update all of us and the population on issues of safety, efficacy, and the activity of these vaccines across high risk groups, which will enhance trust and therefore enhance acceptance and uptake of these vaccines. So there may be some vaccines questions today, but as Christina said, we intend to have invited vaccine experts here next week, joining us on Friday, by which time, of course, the Pfizer vaccine will start to be rolled out, and possibly there'll be new information on additional vaccines. Thank you very much.
Thank you very much, Dean. And we're going to open up to questions really soon. But first, Professor Stephen Reicher is going to say a few words about Independent Sage's updated statement on universities. Stephen.
Thank you. So, cases down, a vaccine approved, and if Spurs beat Arsenal on Sunday, it will be a very good week indeed. But I want to sound a note of caution, because there are 2.5 million students in this country. Over the next week, most of them will be going home, traveling throughout the country and internationally, and they will be returning in the new year. And if you add in the inevitable spike in infections if people mix too much at Christmas and the normal pressures on the health service in January and February, that is a serious situation. And we need to make sure we don't have the same problems at the start of the second term that we did at the start of the first term. Now, on Wednesday, another announcement by the government, you might have missed it with all the information about vaccines, but another announcement was their revised guidance on the return in the new year. And I just want to make 3 points about it, which are central to our new and updated document on universities. The first two are things they have done, and the third is something they haven't done. So the first is they recommend a staggered return over 5 weeks, which we support and which we applaud. It begs the question of why going home is done over 1 week, but we'll let that one go. The one thing we would say is that if students are asked to come back late, then they should be compensated for whatever they would have had to pay on their accommodation in that period. The second point is about testing. The document says that students should be tested on return. Now, it's very vague, and one of the problems is the same things have been said at the moment, and yet it is unclear. There is no systematic survey of the testing that's going on students, of how it's working, of what support they are given, on how it impacts on their behaviour. And there needs to be an urgent national survey of what's gone on in testing in order to make sure there is best practice when students return. But the third point, the absence, is in many ways the most important thing. Since, I think, September, we have been calling for teaching to go predominantly online so that students don't have to go into class. Now, many people have asked why, given that there are precautions in class, but the point is that in-person teaching is the hub around which all sorts of other things revolve. Most obviously, if there is in-person teaching, you need to be on campus to go in, and that leads to crowded halls, which are the places where you get infection. So what Independent Sage is calling for, again, strongly, is that all universities, by default, put things online, such that students have got the choice, and I stress the choice, whether they want to come back to campus in January, February, or whether they want to stay at home and work from home. And there should be no detriment to them for doing so. And the government should support universities in order to make that practical so that students and staff and the community can all stay safe.
Thank you very much, Stephen. And our statement on vaccines and that revised report on universities can be read in full on our website. So now it's time to have some questions. And first of all, some questions from the press, starting with Krishnan Guru Murthy. Krishnan.
Hello, thank you very much. I want to jump the gun a little bit on vaccines and ask a little bit about that. I know you're going to concentrate on this next week, but forgive me. There's been a lot of excitement, obviously, about the implication of the vaccine and returning to normal, and all this talk of being able to return to normal by the spring. Is that realistic? And how many of us need to have the vaccine in order for us to reach the herd immunity threshold? How do we determine what the herd immunity threshold is? Because the implication of what the government press conference seems to be saying was that as long as we eradicate 99.9% of the deaths, the hospitalized deaths at the moment, then we can start thinking about going back to normal. Is that how you see it? And just finally, I mean, is it possible that we never reach the herd immunity threshold and that we're just constantly trying to get there?
Thank you very much, Christian. And so some quite technical questions about how the vaccine is going to work. Professor Deenan-Pillay, I wonder if you'd like to take that.
Thanks, Christian. Well, why don't I just start with regard to sort of some aspects of it, and there'll be others. I'm sure Gabriel will and others will come in with regard to overall population effects. The vaccine is quite rightly is focused at reducing mortality in the high risk. And it's going to take some time to start to whittle through that list that the Joint Committee of Vaccinations and immunization has generated, starting with the highest risk healthcare workers and over 80s and so forth. And I suspect it's going to take until Easter really to cover those highest risk individuals. That's even before we get to the sort of widespread immunization of the whole population, which will be required, of course, if we're to move to herd immunity. We still, of course, don't know that this immunization will stop transmission. The data, the point of the trials, the primary endpoints were all about disease rather than reducing transmission. And whilst it makes scientific sense to infer that there will be an impact on transmission, that's far from clear at the moment. So I think some of the estimates and modeling are based upon major assumptions, and we're not there. So my sense is that it's going to take a long time before we can get to anything like herd immunity. That's the first thing. And just secondly is, of course, we do not know the longevity of the effect of immunization. And already there's talk about the need for these immunizations for vaccines every year if there's waning immunity. And therefore, if we're talking about 6 months from now, from start of immunization, it may be that immunity may be starting to wane, and there'll still be virus circulating, and that would also undercut the idea of herd immunity and elimination. But maybe I'll pass to Gabriel or others to speak about the sort of concept of population protection.
Yes, Professor Gabriel Scally, would you like to comment on that question?
Yes, I agree. I personally don't think we should be talking at all about herd immunity. The vaccine's only been approved, and the trials only took place in people from above 16, age of 16. So it's not going to be licensed for children and young teenagers. So that's a big chunk of the population already who can't have the vaccine at this stage. And until I would suspect, until there are trials in younger age groups, that's the position we will remain in. So there's a big chunk of the population who won't be having it. The second thing is we don't know what the overall effectiveness of the vaccine will be when it's delivered to a population. Although it's 90–95% in trials, we know from other vaccines that when they are deployed in a population, that effectiveness drops for a range of reasons. Sometimes it's to do with the population that's being given the vaccine. Sometimes it's to do with problems in terms of deterioration slightly in the vaccine during the process of its delivery and so on. So, but even if we got to 90%, that would still mean that 1 in 10 people who are immunized won't be immune from the virus. So we're going to have to try and protect them really quite substantially in the meantime. So if you can think of that of a care home or a nursing home with 30 or 40 residents, well, 3 or 4 of them, even if everyone is immunized there, will not be immune, and we need to protect those residents from the virus. So for a whole string of reasons, I think herd immunity is not going to be possible for the foreseeable future. And one should remember, even with diseases with a fantastic vaccine like measles, we still have very large outbreaks of measles in this country, and we have not managed to eliminate measles in this country. So I think we need to concentrate on the realistic scenario. The vaccine is great, it's going to make a big difference, but it's not going to be the whole answer. And that's one of the stories of COVID-19. There is no silver bullet. We need all of the tools to reduce the prevalence of the virus that we can possibly deploy, and the vaccine is absolutely one of them.
Well, this is such a good question, Krishnan, that pretty much everybody on the panel wants to answer it. I'm going to go to Professor Carl Friston next, and then to Susan Mickey, Professor Susan Mickey. Carl.
So just to put some numbers on the key points that Gabriel and Deanan have made, if you run the numbers and the most optimistic assumptions about the take-up of the vaccine, and it is 100% effective in providing protection and precluding transmission, then the best you can hope for is a deferment of a seasonal wave, sometime in autumn, or some convergence to an endemic equilibrium. It is certainly not going to go away. So that's under the best scenario, or vaccination scenario. So what that means is we're back to where we were several months ago. That the only way you're going to achieve community suppression and back to normal is through public health measures, and crucially the test, trace and supported isolation. So from that perspective, if you want this optimistic view of next spring and next summer, then it is only going to be realized if we look at the vaccination program as affording a new opportunity to implement the right kind of public health measures. So that's what the quantitative modelling is showing at the moment.
Thank you very much, Carl. And finally, Professor Susan Mickey on that one.
Yes, I'd like to add two things that this will be dependent on. One is how good the infrastructure is for the implementation of the vaccination programme. And we heard earlier about the continuing problems of the test, trace and isolate system. So is the government going to get a good procedure bringing together all the parts of the NHS and public health that need to be brought together to make this a successfully implemented programme? The other issue is about uptake. Current data is suggesting up to 10% of the people in the UK are rather anti for different reasons, and probably a total of about 50%, at least 50%, what's called hesitant, in that there's lots of questions about safety, about effectiveness, about side effects. And it's going to be absolutely crucial how good communication is and giving of information in order to address the concerns that people have to ensure maximum uptake for population health. So far, the government hasn't covered itself in glory in terms of its communication around the launch of these vaccines. And I hope there's going to be some very fast learning on that one.
Thank you very much. And now moving on to the next question, which is coming from Julian Bergini, who is also a journalist. Julian, are you there?
Yeah, I am. Thank you. Hope you can hear me, Alice. Thanks very much for that. I mean, I think we all appreciate the importance of the work you're doing, and to do your work well, you need to be given the full information. So I was a little bit worried by Christina's comment that the information coming in on testing is currently not being disaggregated between the lateral flow tests and the other tests. And she pointed out that would make the data very hard to interpret. And I was surprised, actually, that given that was important, that it wasn't clear that it was going to be disaggregated. So in a sense, I'd just like to hear a little bit more about this. Who do you have to ask? Who says whether you get it or not? And is this a one-off case, or are you often in struggles to get the information you need?
So this is a question really about data and transparency, isn't it? And I'll hand it straight back to you, Christina.
Well, I don't know who I have to ask. I mean, I know, I'm sure it's available. I'm sure that, you know, that internally they have data disaggregated by it, but it just isn't, well, it's not currently on the dashboard. And various bits of data like test and trace will say, well, this table includes lateral flow, this table doesn't include lateral flow. So you're kind of, okay, positivity data does or doesn't. And I mean, in general, the data that's now publicly available through the government, I mean, there is a lot of it. It has got a lot better, but it's also now in so many different places that it's incredibly difficult to try and work out where everything is. And you have to, you know, it literally takes me hours every week just to try and trawl it in from the different websites. And there hasn't been that much clarity, and that, you know, there are already things that we've been asking for ages. You know, can you disaggregate between screening, you know, or like the test they do every week in hospitals and the test of symptomatic people? That's never happened. So it doesn't fill me with confidence that they're going to do it. But it is like, if mass testing becomes much bigger than it is, if it starts being 30-40% of all the tests carried out, you're going to end up having to try and back calculate it and try and work out from other areas, you know, can we try and understand the impact it's having on case numbers and positivity rates, or you just rely on hospitalizations? And I mean, yeah, it's an issue.
Thank you very much, Christina. Does anybody else want to comment on that? Professor Kit Yates.
I was just going to back up what Christine's saying. Speaking as someone who gathers the data together each week, it does come from a lot of different sources and in different formats, and that is difficult to deal with. We do have a statistics regulator in the UK, so it might be a case of looking to the UK Statistics Authority and suggesting that they have written to the government in the past about their statistics, and suggesting that perhaps they do that again, because this is certainly something that we've identified as being a big potential issue that's, now that mass testing is coming online, is going to get worse, and it's going to make the picture more difficult to discover the underlying picture of what's happening. Are cases going up? Is it just a result of testing? So yeah, the UK Statistics Authority is probably somewhere where we can look to try and ask these questions, to put pressure on the government to give data in the most transparent way as possible.
Thanks very much, Kit. Moving on now to another question coming in from Caroline Malloy, who's a journalist for Open Democracy. Caroline.
Thank you very much, Alice. Yeah, thank you. It's great to hear everyone. And I actually had a question about support and protection, or supported isolation. I think you've referred to it as often. So I just wondered, it's good to see those, tempered optimism about the trends down to some extent. I wondered if there was any information coming through about whether one thing that's impacting on transmission is the introduction of the new financial support, the £500, I think it is, for 2 weeks. And for people's, whether that's impacted on people's compliance and that's on transmission. It does seem like a lot of people are still left out of accessing this support, and I don't know if the level is adequate enough. And I'd be really interested to hear from the experts here on their views on that, and any recommendations they had on whether we still need improvements to the UK system of support, and if so, maybe, I don't know if there's international evidence of what's most effective in this regard.
Thank you very much. Dr. Zubaida Haque, I wondered if you'd like to take that question.
Sorry, I don't know if my headphones are working. I think Anthony came in before me, so I'll let Anthony.
All right.
Yes.
We'll let Anthony sneak in, and then I might come back to you. Anthony.
He hasn't.
Oh, you're muted, Anthony.
Sorry, I beg your pardon. Great question. I just want to say quickly that every member of this panel would get vaccinated. We support the vaccines. They have very high rates of efficacy. If they're approved, we'll all take them. We should be very pleased that that's coming in. Having said that, the figures from Christina this morning really worried me, because case levels are still 7 times higher than when we were banning people coming from other countries. Wales has gone into reverse. The positivity rate is still above the WHO threshold of 5%, where they say you should take very strong measures to bring them down. So I think it's inevitable we're going to surge again, probably by Christmas and New Year. And that comes back to your point, which is we need test, trace and isolate. And everyone focuses on testing. And actually, that's the least important part. Of course, you want to get tests if you can. But the key thing is you want to know how many people are isolating. And all of the East Asian countries and Finland and Australia and Germany and all the countries that have good figures have given generous sickness pay, unequivocal, paid people's bills. And last week we heard the disastrous figure that 4% of people in Liverpool where mass testing is available, only 4% of the poorest people were seeking tests. Why? Because we then heard a figure, and I haven't been able to verify it, that 80% of people applying for this miserable £500 for 14 days had been refused. So, I mean, this is such a short-term, ridiculous measure. As Carla said, we're going to need test, trace and isolate for some time. It's going to take for a long time because we're not going to eradicate this virus. We're going to have another surge. We've lost 15,000 plus people dead since the government refused to put a circuit breaker in at the end of September, which was the advice of SAGE, and we agreed with them. We don't know how many of those deaths could have been avoided, but I think very substantial number. So what you're saying is absolutely crucial. We need isolation figures. We should push up that 500 quid to at least 800 pounds, in my view, and make sure that people get it very generously to stop future outbreaks. And we're going to get outbreaks in the new year because it's going to take us 3 months at least to roll this vaccine out.
Thank you very much, Anthony. Dr. Zubaida Haque.
Thank you very much for that question, Caroline. It's absolutely essential, as Anthony says, that people self-isolate. We have been saying this time and time and time again that, you know, test and trace is quite pointless unless people isolate. And we've been sending that message that also that in order for people to isolate, they need the financial backing, they need the financial support, just as Anthony has said. But it's not just about financial support, it's also about accessibility to that financial support. And you're absolutely right that's raised considerable concerns. Dan Carden last week, the MP who came to Independent Sage, the MP from Liverpool, has raised that issue as well. Problem is, and we've got this fundamental problem, and right now the government is focusing very much on the vaccine, as though all the other issues that were problematic during this pandemic, the test and trace, the self-isolation, the poor raising of, you know, the poor self-awareness, the poor awareness raising, public messaging, all of that, it's as though none of that matters anymore. Now, the vaccine rollout is going to take months and months and months. So we still need all of those, and we still need the self-isolation. So you're absolutely right to raise that that's essential, and the government needs to improve that.
Thank you very much, Zubaida. Moving on to the next question then. It is from Margaret Ehrenberg from Worcestershire. Margaret.
Thank you very much. I'd like some more information that Deenan has already touched on. How come our government or our bodies have approved the vaccine before the other countries in Europe and even in the rest of the world? And given the government's handling of other aspects of the pandemic, can we really trust anything that's going on here? Thank you.
Thank you very much for that question. And I think I'd like to ask Sir David to take that question as a former Chief Scientific Advisor. Sir David. Oh, you're muted. Sir David, you're still muted. We can't hear you.
No? Yes. Can you hear me now?
We can hear you now.
I think the most
can.
important thing to say is that this is our national drug regulatory body, and the MHRA has a substantial international record. They would not be putting that record at risk under any sort of pressure from the government. I'm really sure of that. These are people of integrity who will understand the nature of this particular pandemic and the reason they had to move quickly. But I have to say that I think we can trust their word on this.
Thank you very much. and Professor Deenan Pillay. Deenan.
Yeah, just briefly to add to what Sir David has mentioned, the comparison, I think, with other regulatory authorities, both in Europe and the US, I think is a bit misplaced, really. All these agencies have a very well developed way of working, ways in which they get information, the way in which they then work with a series of experts to guide them and so forth. In some cases, these are done in a public forum. So there are different timelines associated with the rigor that they all have. I think there's nothing to infer that there's different levels of rigor between them all. And of course, the difference we're talking about in terms of time to approval, we're talking about days, also recognizing that that it takes some time for the trials to generate data. There'll be different sorts of data requested by the different agencies according to where they want to scrutinize more. So I don't think much can be read in or should be read in to slight differences in timing about all of this. It's just about processes that are underway between countries. Thanks.
And in terms of that scrutiny, Professor Gabriel Scally, I saw that you'd sent a note as well about the Joint Committee on Vaccination and Immunisation. So it's not just the MHRA.
That's entirely correct. The Joint Committee on Vaccination and Immunisation is the advisory committee to the government about implementing vaccine programs. And they were very clear in their statement that they have reviewed the unpublished phase 1, 2 and 3 safety and efficacy data for the vaccine. And they say it appears to be safe and well tolerated, and there were no clinically concerning safety observations. But Independent Sage view is that all of that data should be made public. We should have absolute transparency about the vaccine, both the data from the trials, but also things like the contents of the vaccine. If you go into a shop to buy a food product, a manufactured food product, you will see on the packaging what the ingredient list is. And the ingredient list for the vaccine should be published as well, so that we can be really assured that the data is good, that the vaccine is good, as well as the work that's been done on our behalf by the MHRA and the JCVI. I'm absolutely content, I must say, with the process. I think it's been excellent.
Thank you very much, Gabriel. And moving on now to another question, this time coming from Tori from Middlesbrough. Tori.
Hi, hope you're all well. I was just wondering, how do we combat the anti-vax movement? The memes against the Pfizer vaccine have already begun, and they spread faster than SARS-CoV-2.
How do we combat anti-vaccination? Professor Susan Mickey.
Well, I think one of the important things is to ensure that the government and whoever are keeping hold of the narrative and not always being in response mode. But I think it's also very important to acknowledge the concerns, the range of beliefs that people have that bring them to the position of doubting or being anti it, and then to address those concerns very directly and ensure that those who are addressing the concerns are people who are trusted by those groups. And the other issue is to not back off from being worried about saying, this is what we know, this is what we don't know, this is what we're certain about, this is where there are still uncertainties. So direct, honest, open communication that uses the language that starts from where the doubting groups are in terms of their level of information, their beliefs, and address things very directly. So that's a start off of how I'd answer that question.
Thank you very much, Susan. Dr. Tallulah Oni, you'd like to comment as well, I think, and then I'll come to you, Stephen.
Yeah, thanks. And just to add to what Professor Mickey just mentioned, I would say three things: measurement, context, and the messaging. So in as much as at the beginning, it's important to share that information and be transparent, it's important that that measurement continues. So they're able to share, well, this is where we are with what we know, this is how the evidence is evolving. These are how many people that have been vaccinated, there's a side effect. So the measurement and transparency around that. Context in terms of participation and engaging people, because they are often or sometimes very valid reasons for hesitancy, particularly in the context of historical discrimination and accessibility, particularly amongst the Black minority ethnic population groups. So really important to engage with those contexts and those lived experiences. And lastly, with respect to messaging, bringing in what we know about other vaccinations. So obviously they're not exactly the same vaccines, but things around, for example, efficacy levels. We assume that people know that 90% is good, but there's been some concerns about whether that's good enough. But actually, a lot of the vaccines that we have no qualms about operate about 50 to 60%. So this is incredibly good. So really bringing in what we know about other vaccination programs would be helpful as part of that messaging.
Zubaida, you'd like to comment on this too. Thanks, Tallulah.
Well, I was going to say we've got more than one group that we should be concerned about. First of all, there's the anti-vaxxers, but actually most surveys have suggested that they're quite a small group who hold those extreme positions. The group that we really need to be concerned about are the hesitant group, and that group is quite large. Susan mentioned approximately 50%, of some populations are hesitant. We know that in a recent study by the Mile End Institute in London, it showed that about a quarter of the population in London said that they were quite hesitant about the COVID-19 vaccine. And that percentage is much higher among BME communities. It's about 37% among BME communities. Now that suggests that actually the government really needs to do an active myth-busting campaign that's targeted towards BME communities, that's targeted towards the hesitant community rather than just the anti-vaxxers. And that really needs to be done. As I mentioned before, the government's public health campaign left a lot to be desired during this pandemic. The best message was stay at home, and then it just deteriorated after that in terms of stay alert and so on. So it really needs to, the government needs to work with Public Health England, with NHS Improvement, and with local public health professionals and GPs in relation to the public health messaging.
Thank you very much, Zubaida. And Professor Stephen Reischer, you'd like to comment as well?
I mean, I'd absolutely like to underline what Zubaida says. The vaccine hesitant are not at all the same as anti-vaxxers. Anti-vaxxers are against vaccines, come what may, and no information will change their minds. There are many people who have questions, and they're quite right to have questions. In fact, it would be strange not to have questions. And if there's a problem, it's not with those people, it's with those who don't provide the answers, which is in part why we're here to provide some of those answers. So I think the first thing is to treat people who have questions with respect, not as a problem, but actually as an opportunity to lay out the information. The second thing is to be completely open and transparent, including with problems. So the vaccine is wonderful, but nothing is perfect. There are going to be some side effects. There are going to be some people for whom it doesn't work. Be open and honest about that right from the start, so that you don't get a backlash later on when you say, oh, yes, incidentally, there are some problems. So I do think that we shouldn't be concerned or worried or dismissive or disrespectful of those who have questions. The issue is up to us as scientists, the government as well, to have that dialogue. And it has to be a dialogue. And on everything, the way we get through this pandemic is not to treat the public as a problem, but to treat them with respect, to treat them as a partner, and to indulge in dialogue with them. So it's two-way, not one way.
Thank you very much, Stephen, and kind of enshrining the whole principles of independent SAGE there as well. We're moving on to our final question now from Teresa Gregory in Oxfordshire. Teresa, are you there?
Hello, yes, I'm here. How prepared are we, the World Health Organization and other countries, for the next pandemic? And how do we best capture the lessons of COVID-19?
That's a great question, because we don't think this is going to be the last time. Professor Anthony Costello, I wonder if you'd like to take that to start with.
It's a very good question. I saw Gabriel coming in, but on the WHO front, actually WHO, despite all the rhetoric against the Director General caught up in the whole US-China dispute, have had a good pandemic in the sense that they argued from day one that you need to find, test, trace, isolate, and socially distance as the basic public health measures you need to take. Early countries got that right. Unfortunately, the US, European countries, and the UK did not get that seriously right. In February, the WHO asked for $700 million to try and help the poorer countries to implement this. When I spoke to Dr. Tedros, the DG, a month later, they had received $1.2 million. So the world does not respond to pandemics generously. The whole structure of multilateralism needs to be rethought. WHO has been through various reform issues, but they don't have the funding they need. Their budget is lower than my university, UCL, annual budget. So, you know, we haven't got our multilateralism right. Hopefully with President Biden coming in, that will improve the international atmosphere. But we have to learn the lessons in this country. We didn't follow the pandemic plan. We looked at the wrong virus. We got our risks wrong. We had the wrong SAGE. We had all kinds of mistakes in place. We have to learn those lessons because there will be a pandemic coming round the corner. I mean, there have been about 8 different viruses that have emerged in the last 20 years, and this is going to happen again. But over to Gabriel.
Gabriel.
Thanks. I think there are 2 things from my point of view as a public health doctor in the UK. One is we have to do more about the health of the population. We came into this pandemic with a population whose health was already seriously damaged. From 2012 on, what we have always expected, a steady improvement in life expectancy, it stalled from 2012 onwards. And we know that for some people, particularly women in the most deprived communities, their life expectancy was actually falling. Now that is a public health emergency, and we did nothing about it. Inequality is widening, and a whole set of public health indicators going the wrong way ever since 2010. And we can't go on like that. You can't have an unhealthy population confronted with a major infectious disease and expect it to end well. The second thing is the public health infrastructure was serially dismantled from 2010 onwards. Regional government offices, the regional health bodies of the NHS, the local health bodies, the primary care trusts in England, abolished. The infrastructure, the state was hollowed out as far as health was concerned, and many other aspects. The government offices of the regions, which used to coordinate emergency response. The fact that we've moved from having public health doctors as chief medical officers. The UK came into this situation with, of the 4 chief medical officers, only one of those chief medical officers was from a public health medicine background. That is not good enough when the job is the improvement of the health of the population. And we do need powerful local figures and local regional figures. We need to empower local directors of public health and give them the resources, the independence, and the capacity to do the job properly next time round. But this is a real matter for an inquiry immediately this pandemic dies down. We need to address the health of the population and the public health infrastructure in the country. Both are urgent because, as Professor Costello says, it might not be another 100 years, it might not be another 10 years, it might not be another year. It could happen anytime. We just don't know. So we need to get on with that as a matter of real urgency.
Thank you, Gabriel. And Dr. Tallulah Oni, you'd like a word on that question as well.
Thanks. I'll just build on Professor Scali's point, because there are two points. The first around vulnerability and reducing vulnerability, which is what Professor Scali mentioned. Do you remember when we were talking about obesity as an important thing to address and save the NHS? Where's that conversation gone? We know increasingly that exposure to air pollution is associated with worse outcomes. What are we doing about that now? The narrative now has shifted to we have a vaccine, so we don't have to worry about that, but we're not thinking about the resilience of the population. So those conversations very much are as urgent as the conversations around vaccination. And then the second point I wanted to make on this was really, in as much as there are some inevitable pandemics that will likely come up, there are also in the works some preventable surprises that we have. And so can we think about preventing potential future pandemics? So what are we doing in terms of disrupting the natural ecology that increases the risk of emergence of new viruses, and how can we reduce that risk? And that is very much part and parcel of thinking about how we build our cities, how we prioritize trade. It really is a cross-cutting issue. So I think it's really important that we think about pandemics, not just in terms of how we react, but how we prevent. And this obviously also is very much tied into mutual synergies and benefits with climate change, which is obviously the big emergency that we're facing at the moment, but really not acting sufficiently against.
Thank you very much to Lula. COVID is not the only challenge facing us. It's time to wrap up for today, but first, as usual, I'd like to invite Sir David King to sum up. Sir David. You're muted.
Hey, I've got it. We've covered the ground rather well. The first thing is vaccines are a wonderful thing to have, but they're not a silver bullet. We, for example, know that the tests haven't been conducted on under 16s, on pregnant women and so on. So there are a number of key exclusions, but we also know that the vaccine hasn't been tested over a length of time. And so we really need all of the other measures in place. And in any case, the rollout of the vaccine is going to take quite a while. And so we really should be focusing once again on find, test, trace, isolate, and support, as my colleagues have been saying. In terms of the vaccines themselves, we've been saying maintaining public confidence will be key. And my colleagues have said this exceptionally clearly, I think. We have to listen very carefully to those who are worried and just put forward what information is available. In terms of the records as to who has been vaccinated, and this isn't a subject that we've covered, it's important to say the NHS general practice records are crucial, and they have a very good proven ability to rapidly vaccinate and record millions of people every year in a very good process. But, and I come back to the points that Gabriel Scali in particular has been underlining, this will need adequate support. So the general practice teams around the country are going to need support to be able to deliver this enormous vaccination and record program. Thank you.
Thank you very much, Sir David. And I think that over the course of these lunchtime discussions, you'll have been aware that everybody on Independent Sage would have the vaccine readily. So we are unanimous about that. Thank you to our panel. Thank you to everyone who's been watching. All the reports that have been published by Independent Sage, including the ones that we've talked about today and for the last 6 months, are available on the website with details of the whole team as well. Next week, we will be joined by immunologist Professor Danny Altman from Imperial College, who'll be able to answer more of your questions on vaccines. Do follow Independent Sage on Twitter if you don't already. We'll be back same time, same place next Friday. Have a good weekend. Stay safe. Keep well.
Thank you, everybody. Bye.
Bye.